The heroin and opioid epidemic, declared a national public health emergency, is a problem surrounded by questions. Joining me at the desk to help make sense of some of the most pressing questions and concerns in relation to addiction, treatment, and support is Jennifer Farringer, Director of DePaul's National Council on Alcoholism and Drug Dependence Rochester area, and Dr. Aaron Fields, an addiction medicine physician and instructor of clinical emergency medicine at the University of Rochester Medical Center. And welcome to you both. I appreciate you being here.
Thank you. Good morning.
So I'm going to ask you this first, Aaron. How does drug addiction work? So whether we're talking about opioids or heroin, how does the body become so addicted that it gets to the point where some addicts in recovery said to me, I will do anything to get it?
I mean, the best analogy I can come up with is if you felt cold, you would do anything it took to get some heat and some warmth. It's that same primitive drive that gets commandeered by the addiction. It's the same brain receptors that respond to opioids that respond to a lot of the internal molecules that our brain makes. They're called endogenous opioids. And those pathways get commandeered by the addiction when it's being flooded with heroin or with prescription opioids. And so that same primitive drive to do what it takes to survive gets directed towards finding and using drugs. And so it's not this conscious choice that people are making to go out and find drugs. It is an inherent drive that they often will describe watching themselves do all the destructive behaviors that got them into the addiction in the first place, but feeling helpless to stop themselves.
Well, Mary Jo and the Polito family, from them to others that I've talked to about this epidemic, there's something that I have consistently heard in my conversations, and that is that immediate access to treatment options in our region is lacking tremendously. And Mary Jo said to me, when you're a heroin addict, you have a window of time when you want help. And when you finally find a place that can take you in and you hear you have to wait a week, 2 weeks, several weeks, that window instantly closes. And so I want to know, is this changing, Jennifer, in our region? Okay, talk about that.
It is, and thank God it is. So are we where we need to be? No, but we've made huge steps. So one of the biggest pieces is the opening of open access. Open access is staffed by multiple treatment providers. It's located at 1350 University Avenue. The intention is that a family member could bring someone in, someone could self-refer, police could bring someone in, someone could come from the ED. Anyway, immediate access to get assessed for what is the appropriate level of care, find the appropriate level of care, identify the first available slot, and then assist with transportation or insurance barriers. So it's not perfect, but it's so far beyond where we were at. And there's open access like things happening as well. So that was the first thing that started in August. It's now in full swing, 7 days a week, 4 p.m. to 10 p.m., purposely, because that's typically when the normal assessment hours close down. But there's 3 treatment providers. There likely will be more by January that have started walk-in evaluations. So they'll set aside time slots, days of the week. Those are all represented in our treatment provider template, where someone can do the same thing, basically. Walk into that treatment provider, get immediately assessed for appropriate level of care, and get into treatment.
So when Jennifer mentions appropriate level of care, this is something that I try to understand. Is there, or I'll ask you to do this, if you can, Aaron, paint what effective treatment looks like. And does appropriate level of care look the same for everybody?
No, everybody needs a different plan for treatment. There are some people who their addiction's more mild. They're using pills, they're not using every day. They've got more of a behavioral dependence or psychological dependence or addiction than they do the physical. And they don't necessarily experience withdrawal. Those people are perfect for an outpatient program where they can still live at home, still be embedded in their community, still have the direct support of their family members. They just need this extra assistance to get some counseling to help understand the behavioral patterns that feed into their addiction. And then there are people who are using much more regularly, who if they try to stop on their own, they're going to develop withdrawal symptoms, which, as I mentioned, that primitive drive is part of those withdrawal symptoms, and you can't fight them as easily. And that's where, as Mary Jo mentioned, the medication-assisted treatment comes in with methadone or Suboxone, and for some people, naltrexone, a complete blocker, to take away some of that craving and to allow you to focus on engaging in treatment.
How do you know if you have found the right plan? Or how does a family know if they found the right plan? I mean, is it a matter of, I don't want me to say trial and error, but is it trying different things to see? I mean, does it come down to that?
No, the assessment process, so what there is now through OASIS is a locator, and that's an online tool to determine what is the appropriate level of care. So it's not a matter of the family trying to figure out, where do I send my child? The first step is getting an evaluation, getting an assessment, finding out, as Erin just described, what is the appropriate level of care? Does this person need medically assisted treatment? Are they further down into the addiction that there's maybe other medical issues going on that perhaps they need inpatient? So there's so many, and everything in between, outpatient, inpatient, medically assisted treatment, multiple levels of care.
Well, the Polito family, they expressed some great concern in regards to pain medication and it being prescribed to Mary Jo for X number of years for back pain due to a car accident, later on a surgery. And Dennis Polito said, it just doesn't make sense to me, because how do you get it so freely and then get to a point that a doctor will no longer give it to her? Jennifer, I've read something that you've written about this. You said between 2010 and 2015 that the amount of prescription pain medication prescribed by doctors in Monroe County dropped significantly. So by how much, and is this downward trend, will this continue?
So a couple things happened. It was 2016, 2015, New York State passed laws where for most cases the allowable prescribing of the pain medications was reduced from 30 days to 7 days. That was a huge step, and that was a New York State law. It wasn't completely implemented, but by the end of that year it was, and I think we're hearing more and more stories of where it truly is implemented. There are exceptions, but for the most part, so this is never about eliminating pain medication. It's about determining what's the appropriate medication, and if you prescribe pain medication, prescribe it for the least amount of time and the least amount of dose, as conservatively as possible, and to consider thinking of alternative therapies or non-addicting things, like, you know, will ibuprofen do the trick? You know, I've heard more and more dental surgeons, for example, saying we don't even go down the road of opioid pain medications. We use ibuprofen or Tylenol or something like that. Or for somebody that has chronic pain, have they tried seeing a chiropractor, an acupuncturist? Have they tried therapeutic massage? There's a variety of ways, I think, that we can do a better job working with pain rather than risk someone going down the road that this family described.
You're nodding. Erin, do you want to jump in on that?
Yeah, more and more insurance companies are now starting to cover alternative therapies such as massage, acupuncture, physical therapy, which has been a conscientious push by healthcare providers and some of the programs in our area, talking to the insurers and telling them, look, this is a problem, this is where this is coming from. You know, my initial training was in the emergency department, and early on in my training, the reflexive response when somebody had acute pain, you couldn't figure out what the cause of their pain was or how to fix it, was to give them a short prescription and tell them to follow up with their primary care doc. We know, and our guts were telling us at the time, this is the wrong thing to do. This is not helping people. And it comes down to getting comfortable, having that uncomfortable discussion with somebody and telling them, look, I don't know why you're in pain. I'm not going to be able to fix it. Here's some things you can try that aren't dangerous.
I want to go to one thing, because I've heard about this, Safe Sober Site. And Jennifer, you have called this a game changer, a Safe Sober Site. Can you talk a little bit about what a Safe Sober Site is? I hear in North Clinton Avenue, we're seeing, yes.
So when I was talking about the open access, and I was talking about the walk-in evals, there's a third way, and the third way is peer engagement. So would I call it a Safe Sober Site? Probably not. I would call it a way to do similar things that we're trying to do in open access, but through peer engagement. So there's staff, there's two of them right now. One is Tuesday afternoon, North Clinton, and that's staffed by peers of Recovery Fitness. And I know you had them in the show last week. Awesome group of people. There's another one on Thursdays in Gates to Recovery. Both use peers. The intention is peer talking to peer. I've been there. I know what you're going through. Let me help you get some help, and here's the resources. So perhaps not the clinical, it's not the clinical assessment, but it can get them to some of the clinical places, and that is, the goal is to get the person still to treatment as quickly as possible.
So We've got about 30 seconds left. I want to give you the closing word. What would you say to families that are saying, we need the resources, are more coming?
Yeah, yes, and please, 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 I mean, that's what I hear from families. If we had only known, I've tried to put under ncadd-ra.org, under our website, under resources, all the resources that I can think of that would help families. So if you go to that page, go to the resource page, you'll find the Monroe County Treatment Provider template, you'll find a referral to all the recovery wraparound services, as well as the opioid brochure.
We have to close for now, but thank you to my guests, to Dr. Erin Fields and Jennifer Farringer. I appreciate both of you sharing your perspective on this. And to access information on programs and services, you did hear Jennifer say this. This is for those struggling with addiction and their families. Be sure to go to ncadd-ra.org. That website is on your screen, and it's how you can learn more about resources through DePaul's National Council on Alcoholism and Drug Dependence, Rochester area.